you start realizing that that's part of it. To know what I want to do is so much understanding when you're not working as far as you have to start something gets triggers or your knowledge and awareness of where there's something going on. So that feeling like it's really not what I want to do, and then that's not my role.
Take a seat. Thank you. So very exciting stuff, Paul.
Yeah, very exciting. And Michelle's my wife's finishing her master's degree in counseling in this month in May. So she's thrilled.
How's your son?
Just from the stuff happening in August, not so but
How old is he? Good?
he's 19. Yeah, he's going back to living right next to the Four Seasons in student housing.
Poor thing.
Yeah, it's like, more than going to Metro, he's going to go to see you. I'm not living on campus next to the railroad. I hate this train. And I said, well, let's look at it. For cheaper.
Wait for him to turn the... All right, so we're going to get started. Thank you guys very much. I'm just going to be real quick because we are a little bit behind and I have to get him to the airport by a certain time. So thank you for taking time out of your personal lives to come on Saturday. It's a challenge, I know. Real quickly, for the people that have never tested with Spectracell, don't know anything about micronutrient testing with us, I'm just in a nutshell going to tell you the differences. So as he's speaking, it'll make more sense to you. We look at cell performance over measuring a level of a nutrient in the serum or looking at urine. Okay, those are very static measurements. We choose lymphocytes because all the biochemistry is happening within the lymphocyte or within the cell. And we want to look at utilization and metabolism, and it also gives us a long-term history of utilization versus, it's kind of like the difference between doing a serum glucose and a hemoglobin A1C. You'd rather have that history, right? So when you look at lymphocytes, you get a 4 to 6 month window of time of utilization. Those are just brief in a nutshell. Anything else you want to throw out there? With the biochemistry, why is that important? Well, biochemistry is happening every second, thousands and thousands of times in our body. So it's not a debate as to if biochemistry is happening. It's how efficiently is it happening in your body. And the thing that drives all those pathways, the things are nutrients, right? So we need to know if we have adequate supplies or not. Otherwise, those processes are going to happen efficiently. And in JAMA, they pointed it out, chronic deficiencies or insufficiencies are going to lead to chronic health conditions. So it's a great preventative test, if nothing else, to screen for. What causes deficiencies? Well, we have biochemical individuality, so genetics. We've got digestive problems. We've got diet. We've got toxins, alcohol, smoking, stress. So you can go on and on of what causes these insufficiencies to build over time. And that's all I'm going to say because he's got a big presentation. This is Dr. Arland Hill. You're going to love him. He's Dr. I call him Dr. Grabowski's protege. So Dr. Grabowski does a lot of our consults and our webinars, and everyone that's spoken with him loves him. So he's just as phenomenal. So without further ado, Dr. Arland.
Thank you, everyone. I want to be the first one to say thank you for taking time out of your weekend, out of your leisure time to come and listen to this information. I've put quite a bit of thought into this and trying to think, you know, no matter what your background is, no matter what your focus is in your practice, I think you're going to find something out of this presentation that you're going to be able to implement in your practice and be able to use and just think through when you're working with your patients. If you look at our topic here being kind of highlighted on dysglycemia, all of us are seeing dysglycemia in our patient population. And that number is not going to decrease, it's only going to increase. And part of what I want to give you as you're going through this is how do you catch this earlier and earlier, and what is the significance of catching that earlier and earlier. So let's just jump right in here. So just to give you an overview, we're going to talk about some of the reasons to address dysglycemia. I'll give you some of the traditional mindset on this because that's obviously important information. We don't want to ignore that, but we don't want to become fixated in that either. We want to think beyond that. So that's where we'll get into some of these non-traditional viewpoints. We'll do a basic physiology review here. I know all you guys know about physiology as it relates to blood sugar regulation. I just want to kind of emphasize a few extra points around that. We'll look at the role of nutrients and functional testing. So as Len was talking about, you know, really why do you want to look at a functional marker versus a static, say, serum marker? What's the difference? What can we glean from functional over static? How do we use these nutrients to correct deficiencies? You know, just because somebody has a B12 deficiency, just giving them B12, it may address the deficiency, but it may not address the problem. So we want to talk about that. Give you a little bit different way to think about this because, you know, this is I'm probably jumping ahead of myself just a little bit here, but one of the things that I want you to take away from this is that when you see a nutrient deficiency on the test, that nutrient deficiency means far more than just there's a nutrient deficiency there. You got to think about the biochemistry behind that and why that patient actually ended up developing that deficiency in the first place, okay? And what's the bigger pattern around that deficiency. And we're going to talk about that. Of course, you want some evidence-based information here. This is not opinion. This is, you're going to see, some of you may even get tired of me putting research studies in here, but I wanted you to walk away from this feeling that you had something that if you wanted to go talk to another clinician, to your patients, that you could feel like you're giving them credible, valid information here. Secondary effects of dysglycemia. We think about these to a degree. We probably don't, as a whole, think about these in the entirety of how blood glucose abnormalities are affecting human physiology. So I'm going to map that out for you. And then I'll give you some case studies that are out of my clinic, and I'll actually also show you some that are out of the medical literature as well that are pretty interesting. So let's all get on the same page when we're talking about dysglycemia here, because really that's kind of a broad generic term. And what we want to do is I think about this more as being as a continuum, a dysglycemic continuum. So you start in the hypoglycemic arena, and then you move over to your pre-diabetes, insulin resistance, all the way into diabetes at its most progressed state. Right? So it's really a matter of where you catch your patient at there. And why do we need to know this? Why is that important? Well, if you look at the raw numbers on this, I want to show you what these are and just kind of, I know you guys have probably seen some of this, but I want to reiterate these because this goes back and it kind of puts a further emphasis on what your patient population is in your clinic. So let's look at this. This is a chart from the CDC looking at the growth of blood sugar dysfunction in the country. It's becoming exponential at this point. So the numbers are just going to continually, steadily increase on this. They're not going down. They're not turning around. And there's multiple reasons for that. You're going to see one of the reasons that I point out in the presentation here that we'll get to is looking at stress physiology and looking at some of the underlying biochemistry behind that. Who in this room can raise their hand and tell me they're not stressed? Nobody, right? Even if you live, and this is kind of an example I use with my patients sometimes, even if you're living in the most pristine environment, as well as we can do it in today's world, you're eating the ideal food, you're getting good sleep, you're still being bombarded with stressors that you don't even really recognize, that our ancestors didn't have to deal with on the same level. We don't have the recovery times, we don't have the rest periods that our forefathers had. So is it any wonder that this is continuing to increase? No, not really. If you break it down within various sectors of the population, the one that I thought was probably most dramatic here is the one that's on the high side. that's looking at Hispanic females. That's basically suggesting, this was over 10 years ago, that's basically suggesting that over half of every Hispanic female is going to have diabetes. And if you look at some of these other numbers for other sectors of the population, they're not very far behind either. I mean, best case scenario, if you're looking at a white male, 1 in 4 white males is going to end up with diabetes. That's not the continuum, that's the actual diagnosis. So what about all the other people that are dealing with the hypoglycemia, the prediabetes, the insulin resistance, all those aspects? So when a patient comes into your clinic and you're trying to look at them and you're taking their history and working through that history with them, trying to determine what their needs are, I have a couple of questions that I automatically throw into every patient history that I'm doing. And these are some of the ones, and I'll point to the ones that I think are probably the most significant here for you, that I think if you ask these questions, you'll probably quickly recognize how big the numbers in the population are of dysglycemic patients. Easily becomes lightheaded, irritable when eating, shaky tremors. Okay, those are all, everybody knows those. Those are all the textbook things that we all learned in school, right? Here's the one that, at least I didn't learn this one in school. If you look at nausea in the morning and don't feel like eating, how many of you guys have ever tried to tell a patient, you need to eat consistently throughout the day? Maybe you're telling them just to try to get them started, you need to have them eat 3 basic meals a day, or you want them to do 3 meals and some snacks, or whatever your variation is. And they look back at you and they go, but I'm not hungry in the morning. How many of you have ever had a patient do that, right? Probably most of us. What that patient is telling you is they're hypoglycemic. And the reason that they're feeling nauseous in the morning is because their sympathetics are kicking in. So that's an automatic clue for you that you're going to want to do some type of follow-up assessment to try to figure out what's driving that hypoglycemic state. The other ones, the kind of more common ones here, the cravings for sweets. The cravings for sweets by itself could be a potentiator of that. But the other one that I really like to ask is, do you get fatigue in the afternoon? Almost everybody I run into now says, yes, I get fatigue in the afternoon if they're not being really diligent about what food choices they're making and how they're controlling their stress habits. So that's another big one. So if you want to look at the 4th and the 6th one there, those are probably the 2 that, if you're only going to ask 2 questions, those are the 2 that I would ask. On the insulin resistance side, probably the best one here is that first question, do you get fatigued after eating? And I'll talk to you, I have a slide to actually give you some of the biochemistry on why patients get fatigued after they eat when they have insulin resistance. But that's a really good one to kind of point you down that track of this patient, probably their insulin levels are probably starting to rise a little bit on them. Maybe they're even to the point of their glucose levels starting to come up a little bit. They equally can crave sugars and sweets, but the key here is that it's a timing issue. It's not in between meals, it's right after that meal. And if you think about that, you know, just kind of on a kind of cursory viewpoint here, it's they can't get glucose into the cell, so they're still looking for something to try to run those energy production pathways. And what better way to do that than with a simple carbohydrate, right? Weight gain when under stress, difficulty losing weight, and the need for stimulants such as coffee. The way you can better define that last point is if you ask a patient, when you wake up in the morning, do you have coffee? Okay, yeah, they have coffee. Do you have the coffee because you enjoy coffee, or do you have the coffee because you feel like you need that coffee to get going in the morning? If it's the latter answer, they're probably starting to give you some indications of a dysglycemic state. Okay, looking at this on a bigger scale. So what are we thinking about with regards to the effects of abnormal blood glucose? So if I ask most of you in here, we're kind of going to begin to think about cardiovascular complications, maybe changes in vision, kidney dysfunction as being indications for abnormal glucose. But if you really think about that, that's pretty far progressed down the pathway. I mean, by the time things have gotten to that point, you've got a lot of other disrupted physiology there. So where we want to focus our attention is going to be down through this area. And what I'm going to do as we go forward here for the first part of this presentation is I'm actually going to start tying in dysglycemia to every one of these different areas, so you can begin to see that it's not just about addressing the dysglycemic state, Because if you look at the way that these arrows present, they're all bidirectional. So you want to deal with the dysglycemia, but you also have to deal with the outer dysfunction around that, because if you don't, it's just going to continue to feed that dysglycemic state, and it's going to frustrate you as the clinician. So let's talk about each one of these. To give you some breakdown on some risk factors here, this is, if you think about where we have come from with the evolution of our understanding about diabetes, for the most part, we've always talked about these sectors right here, these different points right here, because we know that these go hand in hand with dysglycemia. I mean, if you look at blood sugar physiology, you'll see that it's going to start throwing off some of these other areas fairly quickly, in fairly short order. What's not talked about is these 6 bullet points here. And you'll notice this is a fairly recent study. Where I pulled this information from was the exact same place I pulled this information. So this is becoming more prevalent out there. The literature on it's evolving, so we want to take note of it. If you think about metabolic endotoxemia, so if you look at when our inherent detoxification systems aren't functioning like they're supposed to, regardless of what we're being exposed to from an environmental exogenous standpoint, what we produce in our body on a day-to-day basis, those toxins, they have to be cleared out. And if they're not being cleared out, they're just as relevant as anything you're going to be exposed to from your outside environment. Systemic inflammation. I would almost challenge any of you to go find anything related to a chronic disease that's not going to steer you back to chronic systemic inflammation at some point. It all comes back to that. So we need to know about that. Intestinal permeability. So we'll look specifically at what the pathways there are going to be. Your gut microbiota, oxidative stress, and your genes and your environment interplay. This is a common thought pattern, right? You get into downregulation of the insulin receptors, the insulin starts coming up a little bit, and then as a secondary response to that, you get hyperglycemic state, because you just can't get the glucose into the insulin, or into the cell. But what about these other mechanisms? So again, we're going to start working kind of our way around that chart. If you look at the effect of dysglycemia in men, when you look at the ads on TV right now, one of the more common ads that you see out there is for low T, right? Why is low T so prevalent right now? This is one of our mechanisms. This is not the only mechanism, but this is one of our mechanisms. So we know just by virtue of what's being populated or what's being advertised to the populace, we can suggest that this has probably got a hand in play here. And then if you think about it in terms of females, it's not something that you see as much anymore, but maybe 2-3 years ago, there were still quite a few advertisements on television about birth control pills and different types of birth control. And if you think about, well, what's looking at PCOS, one of your interventions there is going to be birth control, right? So we know just by virtue of what's being put out there to the public that we've got a problem at hand here with the hormones and how our blood sugar interacts with those hormones. So in a man, what are you looking at there? You're looking at an increase in aromatase activity, so they're furthering that conversion of estrogen over to, or testosterone to estrogen. And in a female, you're getting the increased production of testosterone from your pregnenolone progesterone precursors there. So let's take a look at what that is. If you've got, looking up here, starting with your cholesterol, working down into your steroidal hormonal pathway, you're going to see here you've got your 1720 lyase enzyme. And then that enzyme gets upregulated when there's a dysglycemic state. And that's going to push you down into this androgenic activity. So that's your female pattern. Well, on your male pattern, it's a different location. You actually get increased activity of your aromatase enzyme here, and you're pushing your androgens over into estrogens. So if we're looking at really, kind of think about clinical practice for a moment here. Let's kind of take the mentality of what's being promoted in the mainstream advertisement. If your testosterone's low, take, I don't know, let's just pick one. Let's just say Androgel, right? Take Androgel or whatever testosterone replacement you want to do. Well, what happens if you've got a male who has a dysglycemic state that ultimately drove him to having low testosterone anyway, and you put him on Androgel? All it does is feed his estrogen. metabolism. It doesn't do anything to really help him in the long run, and actually you probably put him at further risk. Because what you'll see sometimes, actually what you'll see fairly often, is that the harder you push those testosterone levels to try to get that up and create a balance, really all you're doing there is further down regulating those insulin receptors. And further down regulation of that insulin receptor just makes this aromatase activity even more prevalent. So it's really this vicious cycle that they get caught in that the labs a lot of times don't really uncover, and the patient comes back with the feedback, well, I took this dose and it worked for me for a little while, and well, let's try to up the dose a little bit and see how an up dose or an elevated dose works for you, and the dose starts getting titrated up. But it doesn't work. The patient ultimately gets caught where they're still dysglycemic, and now they're doing something that's probably exacerbating the dysglycemia. So this is an overview of PCOS, and I thought this was an excellent slide because this just shows you how out of control that this can get in fairly short order. So if you look at what happens here, you've got the pancreas, and the pancreas is going to produce insulin. And what that insulin, that increase in the insulin is going to do is it's going to tell the pituitary, you need to decrease the production of FSH and increase the production of LH. And what that LH is going to do is the ovaries are going to start increasing the production of androgens. Now, under normal circumstances, when the LH would increase the production of androgens, you would have increased, or not increased, but you would have aromatase activity in the ovaries that would allow that androgen to go over into your estrogen metabolism, right? But that's not what happens here. Because the FSH is downregulated, you don't get that activity of aromatase. Those granulosa cells in there don't have adequate function to aromatize that not the testosterone, but to aromatize the androgens, and thus you get these increased androgen levels. So when you look at this with a PCOS patient, the reason that they're manifesting, whether it's the acne or the hirsutism, or even if you're looking at something real subtle like maybe you're catching some dark hairs on the chin, real subtle findings, that's being driven by ultimately an increase in their insulin levels. Now, that's kind of the classic thought about where most of our thought process is when each of us are dealing with PCOS. That's kind of where we go. But look at what else starts to begin to happen here as a result of the insulin. You're going to get impacts on the liver, and we'll talk more about that in a minute. But ultimately, for this scenario, what's going to happen is the sex hormone binding globulin is going to decrease. And when it does, those androgens aren't getting bound up. So now you've got more free active androgens acting on those androgen receptors, creating those symptoms that we associate with PCOS. If you go one step further with that, one of the things that I couldn't figure out how to put it in here to prevent from messing up the slide, but you've got, and if you increase these androgens, that ultimately feeds back up to your insulin receptors, and you downregulate those insulin receptors again. So the more dysfunctional this becomes with sex hormone binding globulin, the more free androgens you have, the more increase in insulin resistance you have, and it just keeps perpetuating itself. So let's look at a little bit different aspect of hormone physiology here as it relates to dysglycemia. Kind of the way that this starts for a lot of our patients, and there's nothing that really says that a patient has to go into what would be your classic hypoglycemic state or even a reactive hypoglycemic state. Most of our patients, I'm having trouble sitting here thinking off the top of my head, last time I've seen a patient, actually it was a true hypoglycemic patient where I did a lab with them and their blood sugar was down below 65. That's not common. What is far more common than that is for you to have a reactive hypoglycemic. And for it to be a reactive hypoglycemic, that's a definition diagnosis. So if the patient is exhibiting the symptoms that are consistent with that, you don't need a lab to diagnose that, and that's by far where we're going to find most of our patients at here. But I say that only to say that you don't need a hypoglycemic patient. A patient doesn't have to become hypoglycemic before they start transitioning down the road of insulin resistance and so forth. So this is not necessarily to say that patients have to go through each set point on this. They can kind of move around a little bit based on their biochemistry and environmental exposure. But if you look at what can happen here, you get the hypoglycemic state. As a result of that, your body's going to use cortisol and through its action as a glucocorticoid to try to bring that glucose level back up into an ideal range. Over time, what begins to happen here, just like the testosterone did or the androgens did with down-regulating those insulin receptors, cortisol is going to have the exact same effect. I think about this in kind of a simplistic viewpoint. If you think about what cortisol and insulin do, they're antagonistic hormones. I think about insulin as putting things in the cell, and I think about cortisol as yanking things back out of the cell. And they're at odds with each other. And from a basic physiology standpoint, cortisol is always going to win that battle because cortisol is a stress response. It's predominant. It's what our body has to have to survive on a day-to-day basis. But the point there is that if that constant secretion of cortisol happens, these insulin receptors get pushed down, they don't become as responsive anymore, your body starts burning through these nutrients to try to maintain that sensitivity of the insulin receptors, and that's where you end up when you start doing these tests with your patients. That's one of the mechanisms you'll see of how they ended up having a nutrient deficiency related to blood sugar dysfunction. And then you get your ultimate state of hyperglycemia and your secondary inflammatory effects here. So here's a quote from a study. It says, the activation of the HPA axis in the central sympathetic nervous system, so our fight or flight mechanisms, is responsible for endocrine abnormalities, insulin resistance, and down at the bottom, frank disease, including type 2 diabetes mellitus. Okay, so we know it can drive that particular pathway. And then this is what that's going to look like in terms of connecting with the hormones and the different organ systems. You've got your H there being your hypothalamus with your CRH production, going down to the pituitary to give you your ACTH, and then down to your adrenal gland. So out of that, you're going to kick out your cortisol. And cortisol you can look at in one of two mechanisms here. The first we just mentioned as it's going to downregulate those insulin receptors. And the secondary mechanism here is that depending on the amount of cortisol that's being produced and what the overall environment is, you're going to have an increased inflammatory response secondary to that too. So it just really depends on what the overall presentation of your patient is at the time you're looking at this stuff. So intestinal permeability. How many of you associate leaky gut with diabetes? I mean, how many of that is that your first thought about this patient's got diabetes? Oh, I bet they've got leaky gut too, right? So here's why. Let's talk about some of the rationale behind why that is and why we should think about that, because they're pretty tightly linked together. If you look at the specific study here and what they're suggesting, it says that the intestinal bacteria seem to serve as a lipopolysaccharide. So the lipopolysaccharides are going to be your antigens are going to be your immune system stimulators. It's what the immune system is going to tag. It's going to develop a reaction secondary to that. But it says through the LPS and or bacterial translocation, so crossing across that gut barrier into the circulation due to the barrier being broken down, and then ultimately creating systemic inflammation and a progression towards metabolic diseases. So if you remember back, and I'll show you this again, if you remember that slide I had, it had dysglycemia in the center, and then it had systemic inflammation, and then under that it has intestinal permeability. So it's just all three of those points have to be considered when you're setting up your treatment protocols of what am I going to do about the leaky gut? What am I going to do about any additional sources of inflammation? And then how is that affecting my dysglycemia that is ultimately probably what I picked up to address as the primary issue for the patient. And to that point, I guess let me say this, because I think I overlooked this. Two things I tell my patients when I'm starting out, if I depending on what I find in their labs, if they've got dysglycemia or if they've got an anemia, I tell my patients that until we get these two things under control, don't expect to have miracles begin to happen here. You've got to control those two aspects of your physiology, or literally everything will begin to fall behind that. So I try to stress that to them just so they can have an understanding of what their role in their treatment process is. Because ultimately, I always talk to my patients even after I maybe go through a battery of testing with them. What are the two things that nobody really argues about as far as being beneficial for dysglycemia? Diet and exercise. And I can't tell them what to put in their mouth on a day-to-day basis. I can instruct them, I can coach them on it, and I can't go do their exercise for them. So I always, make them take that responsibility away from the visit. if we look at kind of a flow chart of how all this starts to fit together, what you're going to see is kind of your classic scenario of your overnutrition, high sugar diets, the things we typically think about as driving the dysglycemic state. And then what's that doing to the intestinal environment here? Well, it's increasing the ratio of your pro-inflammatory bacteria. Your ability, as that pro-inflammatory bacteria goes up, your ability of your cells, that inflammatory response that's happening at the cellular level in the gut, the detoxification abilities of those cells begins to break down, whether it's because of a malabsorptive state or it's just because of the inflammation continuously breaking that tissue down and not allowing it to be functional anymore. Your overall increased intestinal permeability, and then you're going to have a more likely increase of your bacteria crossing into the bloodstream, stimulating an immune response there. Now, as all that's beginning to happen, that's going to start feeding systemic inflammation here. So now if you look at what begins to happen, these are all triggers for the immune system. And the one that I want to point to here, just to kind of tell you down to what level this happens, is this NF-kappa beta, so your nuclear factor kappa beta here. If you're looking to try to drive production of inflammatory proteins in the body, this is the guy that you want to have at your side. We don't want that happening in our patients. We want the opposite happening. We want this guy pretty silent because we don't want to continue to produce those inflammatory proteins. So as long as there's increased intake or increased dysfunction that's going to drive this, what we think about as our dysglycemic state, it's going to cause gut dysfunction, and that gut dysfunction is going to cause inflammation being driven from a cellular level. So we want to start not only back up here, but we want to address all three points here. Overall metabolic changes, what you're looking at is an increase in adiposity. So increased fat tissue production. But the question with this is, adipose tissue is not dormant tissue, it's active tissue. So what is that active tissue doing, and with what that active tissue is doing, how is that affecting our bigger picture here? And that's where you get into production of interleukin 6. How many, I know pretty much all of you are familiar with doing this, but checking CRP levels in your patients. CRP and interleukin 6 are pretty close. I mean, you can use CRP as a surrogate marker for what your interleukin 6 levels are doing in the body. But if you look at why that's important, I didn't put the citation in here, but I pulled the studies that show that interleukin 6 drives the intestinal permeability just as much as, say, some of your bacteria or a dysglycemic state. So now you've got this literally starting to feed back on itself, and you're precipitating this particular cycle. Let's go one step further with that, because most of us are familiar that when you begin to develop this intestinal permeability, this leaky gut scenario, that your exposure to antigens begins to increase. Here's where you get hit twice with this. Your exposure to antigens is going to increase up here, and then if you look at what happens as a result of your interleukin 6, interleukin 6 starts to drive your Th2 cells, your humoral mediated responses in the body. So now the production of antibodies begins to upregulate. So you've got more antigens, more antibody upregulation, which all goes back to increased systemic inflammation. Right? So this gets to be a pretty nasty cycle that can get out of control pretty quick. This is just kind of a balance scale to kind of show you how all that plays out. One of the ones that I want to mention in here is this PPAR. PPAR is going to be your receptor, just like the NF-kappa beta axon receptors in the nucleus. The PPARs is a receptor where various proteins and fats act on that. The reason I'm bringing this up to you is because this is pretty tightly controlled by, depending on the food choices you make, and by omega-3s. So I want to mention this now just in case, because I don't have a slide about this later. If you look at the micronutrient, the sample reports that you have, you're going to see oleic acid is going to be in the second row down at the end. That oleic acid, when you look at that, that is a surrogate marker for omega-3 status in the body. And I have on one of my case studies, I'll show you the correlation where I actually check the omega-3s in the patient. But just know that when you see oleic acid low, that the patient doesn't have adequate omega-3s, and they're most likely not adequately stimulating this PPAR, which is going to decrease overall inflammation. just to tell you the significance of this, they're trying to find medications right now to act on this or that'll have an influence over this. So it's pretty important. So looking at this from a little bit different viewpoint is the origin of type 1 diabetes in the gut. So the manifestation of diabetes is preceded by the so-called pre-diabetic period that may last several years and is characterized by the presence of circulating autoantibodies against beta cell antigens. So if you look at that, when I first read this, I thought to myself, okay, autoantibodies, we're thinking they're, more type 1 type stuff. But then if you look at the wording and the way that they stated this, several years. Saying several years and saying juvenile, as juvenile diabetes, as we think about type 1, those two terms don't seem synonymous to me, right? So I pose the question, is this adult onset type 1 diabetes? Is that what we're talking about here? So let's go on and look at this a little bit further. Carrying forward from what we were talking about with 2 slides ago, looking at the intestinal permeability here, if you think about the embryonic origin of the gut tissue and the pancreatic tissue, it's all derived from the same embryonic tissue. So you would think, based on that, probably some molecular protein similarities in there, so the likelihood that you're going to start reacting against those proteins in the gut, you probably got a high likelihood that you're going to start reacting against those proteins in the pancreas as well. And then this last point here, interventions aimed to prevent or treat type 1 diabetes in humans should be targeting the gut immune system. So kind of getting to the point where, how literature a lot of times will say, well, it may cause this or there's a potential for it to do that. That's not really one of those statements. It's saying you need to check this. You need to begin to think about this. And here's what the actual name in the literature has become. It's latent autoimmune diabetes in adults. And it's a special form of diabetes that's clinically similar to type 2, but positive for pancreatic autoantibodies. So there is a difference there. We don't, as pretty much all of us have learned type 2 diabetes, we don't think about anything with regards to the immune